are going to be divided into upper respiratory tract and lower respiratory tract. So for the upper respiratory tract, we are looking at the common cold, which has to do with the nose. Then we'll look at sinusitis. We'll look at otitis media, pharyngitis, and tonsillitis. Then when you take the lower respiratory tract, we'll look at epiglottitis, tracheitis, laryngitis, bronchiolitis. We've already done pneumonia, but pneumonia is also part of the lower respiratory tract. So if you are looking at the dividing line, it is from the epiglottis down is the lower respiratory tract, and then above that is the upper respiratory tract. Okay. So the lower respiratory tract infections are the most frequent infections of childhood. In fact, respiratory tract infections in general. And if you take the preschool child, that is a child from 3 years to 5 years, they get about 6 to 8 respiratory infections a year. Most of these are self-limiting infections of the ear, nose, and throat. That's the upper respiratory tract. But the lower respiratory tract ones are potentially life-threatening. And these are the bronchiolitis and the pneumonias. So let's look at the common cold. So the common cold is the commonest infection of childhood. And classically, it will show us a clear nasal discharge or a mucopurulent nasal discharge. That is yellowish or greenish in color, sometimes brownish. And then there'll also be nasal blockage, which is evidenced by nasal obstruction when the child is breathing. Then the commonest pathogens are viruses. So we can have rhinoviruses, coronaviruses, and respiratory syncytial virus. A lot of the time, it occurs in daycare centers, and it's very common in the first year of life. You realize that the longer the child spends in the daycare, the longer the likelihood, the more the likelihood that this child would have common cold. And when you look at a group of children who went to daycare and those who didn't go to daycare, the chances of common cold is higher in the daycare group, even up to the 3rd year of life, compared to those who didn't go to daycare. So what happens is that these viruses are spread by aerosol. So either small aerosol, large aerosol, or direct contact. So a child wipes the hand across the nose, touches another child who rubs her nose with it, and then she can get the virus by direct contact. So that's why it's easily spread in the daycare setting. And when this virus gets into the respiratory epithelium of the nose, it causes destruction of the epithelial lining. And then this is what leads to an acute inflammatory response, leading to the passage of clear nasal discharge. A cough is associated in about 30% of cases. And sometimes there might be a fever, which is like a low grade. It can persist for about 1 week commonly, but about 10% will last beyond 2 weeks. So the physical findings are limited to the upper respiratory tract, and the nasal secretion is usually what you see. However, let's take note that if you see a change in the nasal secretion, or if the mother says that it used to be clear and is now yellowish, it doesn't mean that there's a bacterial superinfection. It is very common, and it's as a result of epithelial shedding, the shedding of the epithelial lining of the respiratory epithelium. It doesn't mean that it has become bacterial, so you need to add antibiotics. Now, when you examine the nasal turbinates, you see that the nasal turbinates are swollen and erythematous. That's reddish. And you know that all these are features of acute inflammation. So how do you manage them? There's no cure for the common cold. So the treatment is supportive. Supportive treatment means that you are treating the symptoms. So if there's a high temperature, you give antipyretics. Paracetamol is good. Brufen is also fine. If there's nasal obstruction, you give a topical nasal decongestant. And I have given some examples dexamethasone or phenylephrine. I must state, in fact, I have to bolden this sentence. Antibiotics are of no benefit. So if you are convinced that this is the common cold, you don't need to give antibiotics. Okay. Now, when there's nasal discharge, that is rhinorrhea, we give antihistamine. So Piriton, cetirizine, they are good. They reduce the nasal discharge by about 25 to 30%. There's also ipratropium bromide, which is a topical anticholinergic agent. If the child has a sore throat, usually you don't do anything, but if it's really bad, you can give paracetamol, which is an analgesic. If they have a cough, you don't need to give them a cough syrup, because the cough is because they have postnasal drip. You see, when you have a cold, there's a lot of secretions, and some of these secretions will drip into your nasopharynx, and we take the cough receptors in the throat and cause you to cough. And so if you give an antihistamine, which will stop the nasal secretion, then the cough will also be reduced. So in management of the common cold, you don't need to give cough syrup. Now, things like vitamin C, guanfacine, which is usually found in cough syrups, and inhalation of warm humidified air is ineffective. However, these days, this is debatable, so I won't go into it too much. So let's move to pharyngitis. So for pharyngitis too, most of them are caused by viruses. But in older children, group A beta hemolytic streptococcus is very common. And when you examine the child, you see that the pharynx and the soft palate are inflamed. And when you check the lymph nodes too, especially the ones around the head and neck region, you see that they'll also be inflamed and tender. So what are the signs that the children present with? You have a sore throat. They usually have a high temperature, more than 38 degrees Celsius. When you look into the throat, you will see exudates. Exudates are pus-like fluid secretions. Then you also have swellings of the neck. Then there's also a cough. There is cold or coryza, and then they may also have diarrhea. Okay. So how do you diagnose it? Usually, if you do a throat culture, it will show you which organism is causing the problem.
Hello, madam.
Yes.
I don't know if the network problem is from my end, but it's like we keep on.
Okay. Is anybody else having that problem?
No, madam.
Let's continue.
Madam,
no, madam. No, madam.
I'm not sure.
No, madam.
Madam, I'm not sure.
So then
Okay, there may be from my end.
Madam,
Thank you.
That's why.
Okay, so the throat culture is considered a gold standard. So how do you treat pharyngitis? Usually you give 10 days of penicillin. And penicillin is very cheap. So amoxicillin is an example of a penicillin. 10 days of that, child should be okay. If the patient has a penicillin allergy, then yes?
Madam, please, you said it's caused by viruses, and
then there's group B hemolytic strep, if you remember. I said the majority of it is caused by viruses, but then group B hemolytic strep is also one of the causes.
Okay, because mostly I see prescriptions and the diagnosis would be pharyngitis, and then always they give antibiotics.
So if you say pharyngitis, it doesn't necessarily mean that it's bacterial or viral. Your diagnosis of pharyngitis stems from the fact that you examine the throat and the throat is red. Okay, the majority of the causes are viral. However, in our clinical setting, because we don't do the throat culture, if you remember from the previous slide, I said that the diagnosis is from throat culture and rapid antigen detection testing. That's what will help you distinguish whether this is viral or bacterial. Well, also you can do a full blood count. If there's lymphocytosis, then you know that this is viral. However, because in our setting, a lot of the time we don't do these, and the temperature is very high, we assume it's bacterial, and so we treat with penicillin. Are you okay?
Okay, madam.
Okay.
Hello, madam.
Yes.
Please, can you, as a clinical feature, can you use the presence of the exudate to differentiate whether this one is bacteria or viral?
Yes. Yes. That is even more common in tonsillitis. But yes, if there are exudates, it's more likely to be bacterial. Okay, so if the child has an allergy, drug history, if there's penicillin allergy, then you either give erythromycin or a first generation cephalosporin like cefuroxime. Commonly, Zinat is what is given on the market. Okay, so you can give that in place of amoxicillin. Okay, so let's go to tonsillitis. So for tonsillitis, tonsillitis is a form of pharyngitis, but so with pharyngitis, you see that the soft palate is inflamed. But with tonsillitis, there's intense inflammation of the tonsils. The tonsils are swellings on either side of the uvula. The central structure seen in the throat, when you say that's the uvula. So on either side of it, you see some rounded collection of tissue. That is what we call the tonsil. So when there's intense inflammation of the tonsils, this is what we call tonsillitis. And often you'd find that there's a purulent exudate in the bacterial form. And commonly it's caused by group A beta hemolytic streptococci. You also have Epstein-Barr virus being a common pathogen. Okay, so it's very difficult clinically to distinguish between the viral and bacterial causes. But clinical features, you would find that they have constitutional disturbance. When we talk about constitutional disturbance, we are talking about a feeling of unwell. So they would present with things like a headache, apathy, they can have abdominal pain. When you examine them, you see that there's exudate on the tonsils. And then here again, you would have the cervical lymph nodes being enlarged. That's a cervical lymphadenopathy. So these are some pictures. The picture on my left, you see that there's reddening of the whole upper part. And you can see the tonsils on either side. The uvula is a structure in the middle. You see these huge swellings on either side of the uvula. That's what I mean by the tonsils. Now, if you look at the picture on my right, you can see some patches, some dots, red dots. That's what we call the petechiae. So you have these small pinpoint hemorrhages. That is also an indication of tonsillitis. Then this is what we mean by the exudate, the white pus-like cheesy material that you see on either side, or where the swellings, the huge swellings are. That's what we call the exudate. Definitely, if you examine a child and you see these exudates, you are definitely dealing with the bacterial infection. Even if it started as a viral, there has been a bacterial super infection. So you definitely need to give antibiotics for this. So antibiotics are often prescribed for severe pharyngitis and tonsillitis, even though only a third of them are caused by bacteria. Okay, and this is because the antibiotics may hasten recovery from a streptococcal infection. And so take note of the duration of the treatment. It's 10 days of treatment to eradicate the organism and to prevent rheumatic fever. Rheumatic fever is a complication of tonsillitis and pharyngitis. If you remember from pathology, we learned about molecular mimicry, where you have a situation where there are some M proteins in the streptococci which causes the pharyngitis, which are similar to M proteins in the cardiac in the heart. And so when there's antibody formation against these M proteins, they cross-react with the cardiac M proteins and lead to rheumatic fever. So in order to prevent this, you treat it very seriously. And if you give amoxicillin, sometimes you may get a maculopapular rash if it is viral, but it's just a rash. It's self-limiting. It's better than not treating and ending up with rheumatic fever. Okay, so sometimes a child keeps coming with, okay, it's becoming too much, so go to ENT and then they might take out your tonsils, and that's what we call tonsillectomy. Now, there are certain indications for tonsillectomy. Some are controversial, but these include recurrent tonsillitis. So if the child gets about 8 episodes of tonsillitis in a year, that's recurrent. If there is a peritonsillar abscess, the inflammation is so bad that there is an abscess with pus, that might be an indication to have surgery to remove the tonsils. Or if the tonsils become so large with recurrent infections that the child has obstructive sleep apnea, then that might be an indication for tonsillectomy. So let's look at obstructive sleep apnea. It occurs in about 10% of children with tonsillitis, and it causes them to snore, and they have sleep disordered breathing. What happens is that their tonsils are so big that they partially obstruct the airway, and so they leave a very small space for air to move in and out, and this is what causes the noisy breathing or the snoring when they are sleeping. And they have this episodic loud snoring and then apnea or cessation of breathing for about 30 to 45 seconds, and then they start again. And commonly you realize that this occurs in obese children. Okay, and because of this, what happens is that they tend to sleep during the day because their sleep at night is disordered. And so children who have other disorders can also be prone to this. For example, hypotonic children with very low muscle tone, those with Down syndrome, those with neuromuscular disorders like muscular dystrophy. And so these are the children that you want to keep an eye on. And in advanced countries, you can have a mask with oxygen that they can apply to help. But in our setting, we don't have that. So this is a recording of a child who had obstructive sleep apnea before and after surgery. So the one on my left is showing the oxygen saturation during sleep. You realize that the oxygen saturation is fluctuating. However, post-operatively, it flattens out and is hovering around 100%. So this is typically what happens during sleep. Okay, so let's move to otitis media. Otitis media is inflammation of the middle ear. And most children will have at least one episode of acute otitis media. It is usually common around 6 to 12 months of age. And up to 20% will have recurrence. So they'll keep having it. And there are reasons why this is very, very common in children. The first thing is that the eustachian tube, which is a connection between the throat and the ear, meaning that if there's any viral infection in the throat or any bacterial infection in the throat, it is easily transmitted to the inner ear, to the middle ear, sorry, because of the shortness of the eustachian tube. Also, the eustachian tube is horizontal rather than vertical. In adults, it's vertical. And so it is slanted away from the ear. And so if you have an infection in the throat, it's difficult for that infection to climb up the slope into the ear. But in children, it's horizontal. So an infection can easily be transmitted into the ear. And so these are the reasons why ear infections are very common in children. In fact, you cannot see a child with fever and not examine the ear. That is it's similar to a crime in pediatrics. Once you see a child who has a high temperature, always make sure that you look into the ear. Now, commonly here too, viruses are common, but can also have some bacteria, pneumococcus, non-typable H. influenzae, and Moraxella catarrhalis. These are the common organisms. So clinically, the child will have pain in the ear and fever. The clinical features are divided into two. You can have pre-verbal children who cannot talk, being very irritable. They cry so much. They are easily upset. They are not the nice, smiley children that you know them to be. And sometimes they may pull at the affected ear, what we call ear tagging. So like I said, every child with a fever must have the tympanic membranes examined. In acute otitis media, you see that the tympanic membrane is red and is bulging. You also see that when you look into the ear, the normal light reflex is not there. Occasionally too, you see that there will be perforation of the eardrum with pus visible in the external canal. So once you see these things, they should tell you that, okay, this child has an ear infection. And otitis media is very, very important to treat because you can have very serious complications such as mastoiditis and meningitis occurring. Okay, so this is otoscopic examination. That is on examination of the eardrum. The picture on the left is a normal eardrum. Now, if you look at the normal eardrum, it has this dull gray look when you look with the otoscope. If the eardrum is inflamed, when you look, you will see it very reddish, and sometimes it looks like it's bulging or it's pushing out towards you. So that will tell you that this eardrum is inflamed. With practice, you'll pick up but it's very easy to see. So this circle that you are seeing is your visual field when you look. So the otoscope has light, and so when you look in, the light is what forms this circle that you're looking. All right. So of course, how will you treat somebody with otitis media? It is painful, so you have to give them analgesia. So paracetamol or ibuprofen is fine. You give antibiotics, and so the antibiotics, you can do amoxicillin, you can give amoxicillin and clavulanic acid, you can give cefuroxime. Here, nasal decongestants are not helpful. Antihistamines are also not helpful. And so if a child comes to you with otitis media, you just need two medications, either paracetamol or ibuprofen, and then amoxicillin, amoxiclav, or cefuroxime, and you're done. You don't need to give ear drop. You don't need to give nasal drop. You don't need to give cetirizine. Okay. So recurrent ear infection can also lead to ear hearing loss, and it's usually common around 1 year of age. So this is a complication, perforation with effusion or pus coming out. So for this one, you may need to put in a ventilation tube, what we call a grommet, which can be helpful. The reason why we need to take otitis media seriously is that it can affect the hearing of the children. And so since this is usually around 1 year of age, that's when the children are learning to talk. If their hearing is affected, they will not be able to start talking early. And that can be a cause of hearing impairment and speech delay. And so this is very important because it can result in learning difficulties in school. So this is a ventilation on the ear. So we move to sinusitis. So sinusitis is an infection of the nasal sinuses, and it is usually associated with pain, swelling, and then tenderness over the cheek if it is the maxillary sinus. Tenderness means that when you palpate the face or the cheek, you would see that the child is in pain. We have ethmoid sinuses, we have frontal sinuses and all that. Now, the frontal sinuses do not develop until 10 years of age. And usually treatment is also the same, antibiotics and analgesia. I'll just show a picture and then that'll be the end of upper respiratory tract infection. So you see the E, where they've written the E, that's the ethmoid sinus. And then the M is the maxillary sinuses. The frontal sinuses are around the forehead, but that is not well developed in children. It usually develops from 10 years and above. And so commonly, if you have a child with sinusitis, it's either the ethmoid sinuses that are inflamed or the maxillary sinuses. Please, are there any questions? So this is upper respiratory tract infection. We'll move on to lower respiratory tract infection. Any questions? Hello?
Madam, please, if the
Please, let's continue.
memory is perforated, what do they do?
Pardon?
If the tympanic memory is perforated as a result, as a complication, what do they do?
So that one you need to refer to ENT. So when there's perforation, sometimes the perforation can heal. And sometimes too, you may need to give some topical antibiotics, because once the eardrum is perforated, it means that the bacteria can travel from the middle ear into the inner ear. So you may need to give some ear drops to help with any bacterial infection in the inner ear.
Okay.
So you can't know exactly what is happening until the ENT looks to the ear.
Okay.
Any other questions?
Yeah, madam, good evening.
Good evening.
Yeah, please, you made mention of for the tonsillitis. I want to know what will be the complication of performing tonsillitis. The tonsil is not having any specific function that when you remove it, it can cause any complications.
No. So the tonsil is an organ of the lymphoid system. It's supposed to help with infection prevention. So actually, if you've been immunized and you have a strong immune system, you shouldn't have any problem. But you know that tonsillectomy is a surgery. And so you can also have complications from the surgery in terms of bleeding, wound infection, also in terms of anesthetic accidents, because the child will have to undergo anesthesia before the surgery. Are you okay?
Yes, madam. Thank you.
All right. Any other questions?
Madam, I
Yes.
want to ask a question.
Yes,
For
go
the
ahead.
sinusitis, is it not necessary to give an antihistamine in the management?
So an antihistamine is usually when there's rhinorrhea. So with sinusitis, what happens is that there's inflammation of the sinuses. So it doesn't present as a dripping nasal discharge. The whole face is painful. So an analgesic and antibiotic should be fine. But if you have nasal discharge, then an antihistamine would help.
Okay, madam.
Are you clear? So you see, I'm not saying that if you have, let's say, common cold, in addition to otitis media, you should just treat the otitis media with your antibiotics and then not give anything for the cold. Okay. If you have the two coexisting, then obviously you need to treat. Sometimes the way we treat conditions, it looks as if they are. If a child comes in with diarrhea and vomiting, in addition to otitis media, obviously you have to give ORS for the management of the diarrhea. You have to give zinc tablets. And then you also have to give antibiotics for the management of your otitis media. However, you have to make sure that the side effects of the antibiotics doesn't worsen the diarrhea, because we know that some of the medications can give you diarrhea. Amoxicillin, for example, can give you diarrhea as a side effect. Amoxiclav can also give you diarrhea. You see, so that is it. Any other questions? Okay, so let's rejoin. Yes, you have a question?
Oh no, let's continue, madam.
Okay, so let's rejoin with the same details, and then we'll do the lower respiratory tract infection.
All right, Doc.
Okay, so let me see you soon.
All right, Doc.